Welcome to IM Updates. This is Yan. In this episode, we'll cover key international guideline updates, new FDA approvals, and real clinical changes in practice from June the 5th to June the 12th. Here's the overview. On June 9th, AHA, ACC, ADA, Ellison published the guideline for the prevention, detection, evaluation, and management of cardiovascular-kidney-metabolic syndrome, or CKM syndrome. Highlights include: first, use CKM syndrome staging, stages 0 to 4, to prevent progression, tailor therapy, reduce cardiovascular events and kidney function loss, and promote regression through lifestyle changes and weight loss. Second, use the PREVENT equations to estimate 10 and 30-year risks for atherosclerotic cardiovascular disease, heart failure, and total cardiovascular disease. Third, regularly assess metabolic risk factors and kidney function in all adults. Fourth, address social determinants of health. Fifth, use interdisciplinary care models for patients with overlap of type 2 diabetes, chronic kidney disease, and cardiovascular disease, with a designated coordinator. Sixth, assess both BMI and waist circumference. Address overweight or obesity via lifestyle modification with adjunctive pharmacotherapy or bariatric surgery as needed to prevent progression and promote regression. 7. In type 2 diabetic patients with or at high risk for cardiovascular disease, use SGLT2 inhibitors, GLP-1 based therapies, or both to improve cardiovascular and kidney outcomes, guided by comorbidities. 8th, use both eGFR and urine albumin to creatinine ratio to guide therapy. For chronic kidney disease with type 2 diabetes or albuminuria, first-line therapy includes RAS inhibitors and SGLT2 inhibitors. Add non-steroidal MRA or GLP-1 therapy if albuminuria persists. 9. In atherosclerotic cardiovascular disease patients, aggressively manage obesity, use cardioprotective agents for type 2 diabetes, and use kidney protective agents for chronic kidney disease to reduce adverse events and kidney function loss. 10. For HFrEF, use quadruple therapy including RAS inhibitors and SGLT2 inhibitors. For heart failure with mildly reduced or HFpEF, use SGLT2 inhibitors as first-line, add GLP-1 therapies for obesity, and consider non-steroidal MRAs for type 2 diabetes and chronic kidney disease. On June 11th, WHO published guidelines for the clinical management of filovirus disease 2026. Key recommendations include: first, perform laboratory monitoring based on clinical need. Essential tests include glucose, electrolytes, creatinine, CBC, coagulation studies, malarial RDT, pregnancy test, and lactate. Second, use a protocolized rehydration regimen for patients with ongoing GI losses and dehydration, with careful monitoring for fluid overload. Third, use balanced crystalloids like Ringer's lactate over normal saline for acute fluid resuscitation. Fourth, serially measure lactate as part of perfusion assessment to guide IV fluid therapy in patients with shock. Fifth, use capillary fill time as part of perfusion assessment to guide fluid management. Sixth, in patients with shock receiving IV fluids, start vasopressors early rather than late to reduce pulmonary edema. Seventh, for patients requiring a vasopressor, use norepinephrine rather than dopamine or epinephrine to reduce mortality and arrhythmias. Eighth, initiate vasopressors via peripheral IV rather than central lines to enable faster treatment. Ninth, use ultrasound guidance for central venous access to reduce arterial puncture and other complications. 10th, use broad-spectrum antibiotics when sepsis or bacterial co-infection is suspected in confirmed filovirus patients. 11th, Do not use tranexamic acid for filovirus-associated hemorrhage, except postpartum hemorrhage. 12. Use IV tranexamic acid within 3 hours of birth or postpartum hemorrhage, per standard WHO guidance. 13. Offer all survivors structured follow-up to address mental health, ocular disease, viral persistence in sanctuary sites, and safe delivery for pregnant survivors. Move on to new FDA approvals. On June the 12th, the FDA approved capivasertib or TrueCap in combination with abiraterone and prednisone for adults with metastatic androgen pathway modulation naive or sensitive prostate cancer, previously referred to as metastatic hormone-sensitive prostate cancer, that is PTEN deficient as detected by an FDA-authorized test. The major efficacy outcome measure was investigator-assessed radiographic progression-free survival, or rPFS. Overall survival was an additional efficacy outcome measure. The trial demonstrated a statistically significant improvement in rPFS for capivasertib and abiraterone compared to placebo and abiraterone. Median rPFS was 33.2 months in the capivasertib arm and 25.7 months in the placebo arm. Hazard ratio is 0.81. Overall survival results were immature at the time of rPFS analysis. The prescribing information includes warnings and precautions for hyperglycemia, diarrhea, cutaneous adverse reactions, and embryo-fetal toxicity. On the 12th, the FDA approved Belzutifan, the brand name is Welireg, in combination with pembrolizumab, the brand name is Keytruda, or pembrolizumab and berahyaluronidase alpha PMF, the brand name is Keytruda QLEX, for the adjuvant treatment for adults with renal cell carcinoma with a clear cell component at intermediate high or high risk of recurrence following nephrectomy, or following nephrectomy and resection of metastatic lesions. The major efficacy outcome measure was investigator-assessed disease-free survival, defined as time to recurrence, metastasis, or death. A statistically significant improvement in DFS was demonstrated as a pre-specified interim analysis with 186 events in the Belzutifan with pembrolizumab arm and 246 events in the placebo with pembrolizumab arm. Hazard ratio was 0.72. Median DFS was not reached in either arm, and overall survival data were not mature at the protocol pre-specified interim analysis. The Belzutifan prescribing information includes a boxed warning for embryo fetal toxicity and warnings and precautions for anemia and hypoxia. The pembrolizumab prescribing information includes warnings and precautions for immune-mediated adverse reactions, infusion-related reactions, complications of allogeneic hematopoietic stem cell transplantation, and embryo fetal toxicity. That's all for today. Enjoy your weekend and see you next week.